All right, welcome everyone to today's mini lesson on rheumatoid arthritis. I'm ChicagoDLSinc. I do group sessions and one-on-one tutoring for the Naplex and the MPJE. Shout out to PharmaTurtles and Suspicious Bunch for arranging this. I use RxPrep and Past Naplex now as my resources. Both are excellent. Whichever one you choose for your prep, make sure you do it thoroughly. If you feel that one of them is not preparing you for a certain topic, supplement it with additional resources. If you're new, if you have any questions or concerns, save them until the end. And this is not comprehensive, and this is not a substitute for your studying. So let's start with some background. Rheumatoid arthritis is an autoimmune disease that can cause chronic inflammation of the joints and other areas of the body. It is more common in women. Some symptoms are morning stiffness, typically of fingers, and it's usually symmetric, both sides of the body. And it is three or more joints or areas at one time. Now, rheumatoid nodules can be present. This is a later manifestation, and on the bottom right, you should see a picture. Serum rheumatoid factor, these are abnormal serum antibodies that can be found in 80% of patients. Now, a negative rheumatoid factor test does not rule out RA. And x-rays or radiographic changes, and there will be positive changes. So now let's talk about biologics or biosimilars. Biologics are large molecules. They're a class of drugs that are produced using living organisms. A biosimilar is a biologic, and in terms of safety, purity, potency, there are just minor differences. The active ingredient in a small molecule drug can be recreated. Therefore, a generic drug is exactly the same as a brand name. The complex nature means that slight variations do exist with all biologics. So remember that this is different than, say, metformin, because the small molecules are where they're exactly known, they can be recreated exactly. So both biosimilars and generics are FDA approved of versions of brand name products, and we have biosimilars and generics to increase competition, decrease prices, and improve patient access to medications. Now, let's talk about some anti-inflammatory treatment options. So NSAIDs do not prevent or slow joint destruction. They provide some symptomatic relief. And they're not appropriate for monotherapy. They should only be used in conjunction with DMARDs. DMARDs are going to be disease-modifying anti-rheumatic drugs. Corticosteroids are potent anti-inflammatory agents that can slow the progression of joint damage in RA. So we all know that there are side effects for long-term use, and they are reserved for brief periods of active disease. More of adjunct therapy. You can also do low dose or 5 to 10 mgs of prednisone as bridge therapy until the DMARDs take effect. Rayos is the brand name for delayed release prednisone, and it's available in 1, 2, and 5 mg tablets taken with food, which increases absorption, and the shell breaks, releasing prednisone about 4 hours after administration. Because it's delayed release, we do not chew, crush, or split the tabs. It can be taken at night to decrease morning stiffness, and that's a picture of Rayos on the right side. Now we have the disease-modifying drugs for rheumatoid arthritis. First, we have methotrexate, hydroxychloroquine, which is HCQ, sulfasalazine, leflunomide, gold, azathioprine, or D-penicillamine. These all can halt or slow down RA progression. This is not a Naplex question, more of a trivia question. Who knows the symbol for gold? The periodic symbol for gold? Please type that into the chat. Just want to make sure that you are with me. So, non-biologics should be started within 3 months of diagnosis. And most patients will start with methotrexate or leflunomide. The brand name is Arava or Areva. Patients with milder RA can start with HCQ or a different disease-modifying drug. Does anyone know for good job if you chose AU? That is correct. Does anyone know a brand name for sulfasalazine? A brand name for sulfasalazine. Or if you're not sure of the brand name, feel free to tell me the class of drugs that sulfasalazine is in the chat. So biologics should be usually saved for patients who don't respond to non-biologics. Most will start with a TNF blocker such as Enbrel, Humira, or Remicade. Patients with a poor prognosis may get Orencia or Rituxan. All right, so I have one response. It is azolfidine. Good job, TZ. And just know that the drug class is sulfonamides. Sulfonamide. So if you see a question about sulfa allergy, sulfasalazine is out. So on the right side, we have the Enbrel short-click auto-injector. It is sub-Q, and it is a TNF blocker for RA. All right. So here is a list of non-biologic disease-modifying drugs. On the right side, tofacitinib, the mechanism of action, it blocks JAK, and that reduces inflammation and the antibodies. On the bottom right, you'll see a picture of Illumiant, and no, that is not the actual size. So, Oranofen, which is the gold, MTX, which is methotrexate, leflunomide, azathioprine, D-penicillamine, HCQ, sulfasalazine, tofacitinib, baricitinib, and upadacitinib. Xeljanz, Olumiant, and Rinvoq are much easier. So, biologic agents. This is rheumatoid arthritis as a whole is very high yield, and you're guaranteed to get one question probably per block when you take an assessment or you take the Naplex. There's so many high yield topics or questions when it comes to RA. So the biologic agents, you have interleukin 1 receptor antagonist or Kineret, that's sub-Q once a day. You have 5 TNF blockers. You have Humira, which is 40 mg sub-Q every other week. You have Enbrel, which is 50 milligrams sub-Q once weekly. Remicade, which is IV infusion every 8 weeks. Simponi, which is sub-Q once a month or IV every 8 weeks. And Cimzia, which is sub-Q once or twice a month. Now we have a T cell activation inhibitor, which is abatacept or Orencia. This is IV or sub-Q. And then rituximab, which is the CD20 monoclonal antibody, that is IV. Last but not least, we have 2 IL-6 inhibitors. We have Actemra and we have Kevzara. And Actemra is IV and sub-Q, and Kevzara is only sub-Q. And a picture of Kineret on the right. So to review, we have TNF blockers. We always recommend a PBD test for TB for starting therapy, and then also a PPD test for Xeljanz and Actemra. TNF blockers can cause or worsen heart failure, so we always caution patients that have a diagnosis of a heart failure. Next, we will check a CBC for all disease-modifying anti-rheumatic drugs, and do not give live vaccines such as Zostavax to patients on a biologic DMARD or tofacitinib. On the right, there's a picture of the Actemra autoinjector, which is tocilizumab. Continuing the review, we have methotrexate is recommended as first line. If needed, we can add sulfasalazine or hydroxychloroquine or a biologic DMARD. TNF blockers are typically the first-line biologic agents prescribed after an inadequate response to DMARD therapy, often in combination with methotrexate. Save Xeljanz for more severe RA cases. You may add a steroid for a few months if needed to reduce symptoms until DMARD start working or for acute flares. Always, always, always encourage patients to report fever, malaise, other signs of infection, etc. Bottom right, we have a vial for Remicade 100 mg. Now let's break down methotrexate a little more. Some brand names are going to be Trexol, which are per oral tabs, Zapmep, which is a solution, oral, Otrexup and Rasuvo, which are sub-Q auto-injectors. They are preservative-free. So methotrexate mechanism of action, it is an anti-metabolite chemo agent. It is cell cycle specific. It is an S-phase toxin, and that's the DNA synthesis phase. It's also a folic acid structural analog, and therefore it competitively inhibits DHF reductase. It also inhibits de novo pyrimidine synthesis. Now let's talk about some indications for MTX. We have ectopic pregnancy, which is category X. This is an off-label use. We also use it for psoriasis, cancer, chemotherapy, and rheumatoid arthritis. Now, dosing for rheumatoid arthritis is orally once weekly. Common medication or prescribing errors seen in retail and in hospital is it's prescribed once weekly, but it's given once daily, leading to toxicity. So initially we'll start with 7.5 mg Q weekly or 2.5 mg every 12 hours for 3 doses per week and adjust it to optimal response. Max dose is going to be 20 mg per week. Recommend 1 mg per day folate, except on the day that you take your methotrexate dose to decrease adverse effects. It does not decrease efficacy. If you do sub-Q treatments, you do once a week, similar for rheumatoid arthritis and severe psoriasis, 7.5 mg once weekly. You can also do it IM. Now, for rheumatoid arthritis, it's very efficacious, greater than 85%, and we see a response in 4 to 6 weeks, which is faster than other disease-modifying drugs. Now, for monitoring, we'll obtain baseline CBCs, chest x-rays, liver function tests, and renal function. Always educate the patient that this is a weekly dose, and with daily dosing, the drug can be fatal. Does anyone know, uh, I'll save that question for later. Antidote is leucovorin, and there's a picture on the right. Male and female patients should practice birth control, and the drug interactions are going to be NSAIDs, salicylates, protease inhibitors, and Bactrim. Does anyone know any protease inhibitors? I will accept brand or generic. Please type any protease inhibitors into the chat. Tell patients to call their physician if they develop signs of infection, coughing, or shortness of breath, which represents pulmonary toxicity, or unusual bleeding with liver or bone marrow suppression. So, anyone with protease inhibitors, please type that into the chat. Okay, so uh, ritonavir, sequinavir, any of those would have been acceptable. There are a few more. If you're not sure, remember, please make a note and go back and study. And if you are able to do it after today's session or tomorrow, it will also help with your retention. Tiprinavir, sequinavir, fosamprenavir, lopinavir, boceprevir, simprevir, and darunavir are all protease inhibitors. All right, very good. So this is truly a mini review. Next time we do it, next time around, I will beef it up. We have 4 practice questions. I will read the question, and when I'm done reading the question, please type your answer into the chat. If you're not sure, you can put a question mark next to it, signifying that it is a guess, or just guess, no problem. If you're not sure, please make a note, or you don't want to choose an answer, please make a note and go back and review the topic. And I have 4 practice questions for today. Practice question 1. A 45-year-old male, 48-year-old male presents with an acute exacerbation of his rheumatoid arthritis. He is currently on MTX 7.5 mg weekly. Which of the following would be most appropriate to acutely relieve the pain symptoms? Choice A, increase MTX. Choice B, add Tylenol. Choice C, add Advil. And choice D, switch to HCQ. All right, I'm getting a bunch of C's, which is good. Can anyone tell me the generic for choice B? The generic for choice B, please type it into the chat. All right, very good. So if you chose choice C, oh, oops, the arrow is wrong. I'll fix that. It is choice C. C is the correct answer. Switching to another DMARD or increasing MTX may be considered long-term, but for now we want to relieve immediate symptoms, so that's why we would choose NSAIDs. So choice C is correct. I'll fix that arrow. Tylenol will relieve the pain, but it will not reduce the inflammation that's causing the pain. All right, great job if you chose C. Let's go to the next one. Which of the following would be appropriate monitoring for adverse effects of HCQ? Choice A, routine foot exams. Choice B, routine eye exams. Choice C, CPK, especially with the statin therapy. And choice D, neuropathy. Along with your answer choice, please type in a brand name for HCQ. And if you don't know, that's okay. Remember in these sessions is where it's okay to guess or not be sure, so we can clarify any gaps in the knowledge, resulting in you doing much better when you take the Naplex. All right, good. So choice B is correct. And yes, a brand name is Plaquenil. Very, very good. So HCQ is an anti-malarial drug that is also used to treat autoimmune conditions. We use it in RA and lupus. One of the adverse effects or potential side effects is retinopathy, and it can lead to vision loss. So regular eye exams before and during treatment are important. Great job. Great job. All right, practice question 3. A 42-year-old female with past medical history of RA is scheduled to go to Ecuador in 2 months. She has a significant past medical history for RA, asthma, and GERD, for which she takes MTX 15 mg weekly PO. Advair Discus 50/250 micrograms, 1 inhalation BID, and omeprazole 20 mg daily. She makes a travel clinic appointment at the county health department to determine which vaccine she should receive. Upon questioning by her nurse, the patient reveals that she is due to begin etanercept therapy this coming week, in addition to her methotrexate due to increased worsening of symptoms. The nurse determines that based on where she will be traveling in Ecuador, she should receive an annual flu vaccine as well as yellow fever vaccine as part of her overall regimen. Which of the following is appropriate regarding administration of these vaccines? Choice A, it is appropriate to give both the yellow fever and flu mist quadrivalent vaccines either before or after starting etanercept therapy. Choice B, it is appropriate to give the yellow fever and flu mist quadrivalent vaccines before starting etanercept therapy. Choice C, it is appropriate to give the yellow fever and inactivated flu vaccine before or after starting etanercept therapy. Choice D, it is appropriate to give the yellow fever and inactivated flu vaccine after starting etanercept therapy. So this is good in terms of wording. It's a really good question. Right. So some chose C and some chose D, but they're not sure. The correct answer is B, and let's talk about why. Live vaccines are not recommended to be given after starting biologic therapy. So etanercept is a TNF alpha inhibitor. So yellow fever should not be given after starting. So that would rule out choice A, C, and D. So here the wording was very important. We can give yellow fever and flu mist quadrivalent before starting, but we cannot give yellow after starting. So choice B was the correct answer. Sharmut, can you clarify how long do we space out? And remember that with biologic therapies, you also have to consider reactivating TB, hepatitis B, stopping during active infection as well. Oh, that makes a lot of sense, and I will look that up and type it into the chat. All right, very good. Very, very good. Let's go to practice question 4. Yeah, BJ is a 28-year-old female who presents to your pharmacotherapy clinic with complaints of joint swelling and tenderness in both hands. She has been using acetaminophen, but she states that it hasn't been effective. She reports that her symptoms have progressed over the past 2 weeks and include numbness and tingling in both hands, fatigue, and general malaise. She had tried ibuprofen consistently for several weeks a month ago with no help as well. Upon completion of lab tests, imaging, and a physical exam, the patient is diagnosed with RA with high disease activity. The rheumatologist wishes to begin treatment. Past medical history: hypertension, dyslipidemia, PE 2 months ago. Allergies: sulfa, anaphylaxis. Social history: no smoking, no drinking. Meds are going to be Zestrol, 20 mg daily, Arin, 0.35 mg daily, acetaminophen is 500 mg BID as needed, Pradaxo 150 mg BID, Crestor 20 mg daily. Labs are going to be sodium 137, potassium 3.6, chloride 97, BUN 15, serum creatinine 0.8 mg per deciliter, creatinine clearance a good 98 ml per minute. Vitals are going to be 130 over 76 BP, heart rate's 96, respiratory rate of 12, 98.6. Weight is 86 kgs, height is 67 inches. The rheumatoid factor is positive. X-ray shows joint space narrowing in affected joints. Negative, HCG. Which of the following would be appropriate options to initially manage this patient's RA? Select all that apply, please. Choice A, azolfidine. Choice B, Rheumatrex. Choice C, Otrexup. Choice D, Rinvoq. And choice E is Olumiant. Also, Sharmu, to answer your question, how long do we wait? It looks like 4 weeks is the consensus. So if you give a live vaccine, wait 4 weeks before starting the biologic. Just wanted to share that update with you. 4 weeks seems to be the consensus. All right. Anyone else have any select all that apply answer choices? And does anyone know the generic for Zestrel? The generic for Zestrel. Please be so kind as to place that into the chat. Remember, brands and generics are very important. In the resource section, there are two links, one for 300, top 300, top 200 brand names and generics. I personally think 300 is what you should aim for, just to be prepared. And you don't have to memorize them all in one day. Break them down into 10, 20 at a time. All right. Now this question, lisinopril is correct. Has two correct answers, B and C. B as in boy, C as in cat. Now, this tests area 1, which is obtaining, interpreting, assessing data, medical or patient information, as well as area 2, identifying drug characteristics. Area 3, developing or managing treatment plans. So which category would it fall into in the Naplex? Not sure. but it is good to know that you're practicing three different skills at one time. So let's talk about why choice B is correct. Methotrexate is first line and highly recommended over HCQ or sulfasalazine, as well as a biologic or biosimilar. So let's discuss choice C. And there's no contraindications to methotrexate. So we know that methotrexate is teratogenic. However, the patient is taking Arin and they are covered. Arin is norethindrome. So choice C is also correct. Otrexup is the sub-Q methotrexate and is a viable option. So oral dosage form versus sub-Q. There is some data that suggests sub-Q is superior. However, both are excellent. I would always suggest start with oral before you do any injectables. And that was actually a question one of my former students got was uh, how long do you wait for a long-acting injectable or an LAI version of medication? So uh, always start with oral and then you can transition to sub-Q. So choice B is correct and choice C is correct. Remember with methotrexate, you want to do CBC, liver function testing, renal function testing, as well as the chest x-ray to start, and then regular for the liver function and CBC. All right, so that is the end for today. Does anyone have any questions or concerns about today's presentation, the Naplex, or the MPJE in general? If you have taken an assessment and this is your first time, I'd be happy to discuss your score report over direct message or private message. If you've taken the Naplex before and are preparing for it again, please share your score report. Happy to take a look and provide feedback. Anybody have any questions or concerns for today? All right, welcome. You're welcome, everyone.